Well, if I'm asked what the impact of this new consensus guideline on clinical practice is, we first have to clarify what we are speaking of, because this is a consensus guideline. We'll say this is not a clinical practice guideline as other ESMO formats. Here in this consensus guideline, we were specifically addressing some questions for clinical situations where there's not such a great evidence and where we need the consensus of the experts. However, there are some changes compared to the last years. The first is we have now more molecular markers which should be tested beyond RAS. We now have a recommendation to have BRAF being tested in all patients because this also has an implication on the treatment intensity. Second is we are still dealing with different treatment intensities and allow different treatment intensities. First line sequential treatment to very intensive treatment, all can be correct regarding to the multifactorial decision making. And the third innovation is, and this is really new, that these guidelines recommend the use of local ablative treatment as early as possible. So we'll say if patients have limited metastatic disease, as we call oligometastatic disease, and can be candidates for physical destruction of metastases by radiofrequency ablation, radiotherapy, whatever, this should be used after 4 to 5 to 6 months of treatment of chemotherapy, and then give the patient the chance to be off systemic treatment for a certain time. So we say it's about strategy, it's about molecular selection, and it's about integration of ablative treatment. So free big group of innovation. I think this will have an impact on the daily practice.